Understanding the differences between bipolar II disorder and major depressive disorder is crucial for anyone preparing for a licensing exam in mental health. Although these conditions often share overlapping symptoms, making them appear quite similar at first glance, accurate diagnosis is essential for effective treatment planning. Misidentifying one for the other can lead to inappropriate interventions and impact patient outcomes. As we begin, it's important to recognize the key features that distinguish these disorders. We'll highlight the specific symptoms and patterns you should pay close attention to when assessing clients. This foundational knowledge will help you approach exam questions with confidence and clarity. Bipolar II disorder is defined by having experienced at least one hypomanic episode and one major depressive episode. According to the DSM criteria, a hypomanic episode must last for a minimum of 4 days and is characterized by symptoms such as reduced need for sleep, increased energy, and a tendency to make impulsive or risky decisions. On the other hand, a major depressive episode requires the presence of 5 or more symptoms over a 2-week period. These symptoms often include a persistently low mood, loss of interest in usual activities, and noticeable changes in sleep patterns, among others. Understanding these criteria is essential for accurate diagnosis and effective management of the disorder. Major depressive disorder is characterized exclusively by depressive episodes without any signs of hypomania or mania. To meet the criteria, a person must experience at least 5 symptoms over a 2-week period, which is similar to the depressive phase seen in bipolar II disorder. However, the key distinction is the absence of any history of elevated mood or increased energy. It's important to carefully assess for these features, as their presence would suggest a different diagnosis. In major depressive disorder, the focus remains solely on persistent low mood and related symptoms. Bipolar II and major depressive disorder share several key features, especially when it comes to depressive episodes. Individuals with either condition often experience a persistent low mood, a lack of motivation, and noticeable changes in sleep and appetite. Difficulty concentrating is common, and some may grapple with thoughts of suicide. These symptoms can significantly impact daily life, making it hard to perform at work or school. Social withdrawal is also typical, as people may distance themselves from friends and family. Overall, both disorders can leave someone feeling isolated and unable to move forward. It's important to recognize the key differences between bipolar II and major depressive disorder. Bipolar II is marked by hypomanic episodes, which involve increased energy, reduced need for sleep, impulsive decisions, and noticeable mood swings. In contrast, major depressive disorder is characterized solely by periods of low mood without any hypomania. Factors like the age when symptoms first appear, family history of mood disorders, and how someone responds to medication can help distinguish between the two. Notably, individuals with bipolar II often require mood stabilizers as part of their treatment plan. Sarah, a 28-year-old professional, presents with a complex pattern of mood changes. She experiences prolonged periods of depression, marked by low energy and motivation. However, these episodes are punctuated by stretches of heightened activity, during which she feels unusually energetic, sleeps very little, and often makes impulsive decisions. While her productivity at work can soar during these times, she occasionally overcommits, leading to stress and unfinished tasks. Sarah's family history is notable for her father's diagnosis of bipolar I disorder, and she has found that antidepressants tend to make her feel overly stimulated. Concerned about the impact on her job and overall well-being, Sarah is seeking guidance and support. Sarah's diagnosis aligns more closely with bipolar II rather than major depressive disorder for several reasons. She experiences hypomanic episodes, which are characterized by brief periods of increased energy, impulsive decision-making, and reduced need for sleep. These episodes are not present in major depressive disorder. Additionally, her depressive episodes meet the criteria outlined in the DSM for bipolar II. Her family history and specific reactions to medications further support this diagnosis. Identifying these patterns is crucial, so it's important to ask detailed questions about her symptoms and experiences. Michael is 42 years old and has been struggling with persistent feelings of sadness and fatigue for several months. He finds little pleasure in activities he once enjoyed and often sleeps excessively. His sense of self-worth has diminished, and he has gained weight due to changes in his appetite. At work, he has difficulty concentrating and feels that others might be better off without him. Unlike some mood disorders, Michael does not experience bursts of energy or engage in risky behaviors. His symptoms remain consistently low. There is no known family history of mood disorders, but he has responded positively to therapy in the past. Michael's symptoms align closely with major depressive disorder because he has experienced persistent depressive symptoms for over 2 weeks, which have significantly impacted his work and social life. Importantly, he has never had episodes of hypomania or mania, which are required for a diagnosis of bipolar II disorder. The absence of these high-energy periods makes bipolar II unlikely. Additionally, there is no family history of bipolar disorder, further supporting the diagnosis of major depressive disorder. The combination of these factors helps distinguish his condition from bipolar spectrum disorders. To summarize the essential points for your exam, remember that bipolar II disorder involves both hypomanic and depressive episodes, while major depressive disorder is characterized solely by depressive episodes. When assessing clients, it's important to inquire about mood fluctuations, family psychiatric history, and their responses to medications. The progression and treatment strategies for these conditions differ, so recognizing the distinctions is crucial. Understanding these core differences will help you accurately identify and manage each disorder. The key to differentiating them lies in careful evaluation and attention to these details.